we are, Hiroo, can you sit down? We are quite behind, so we're going to do basically one question per speaker. So if anyone from the audience has to come up, has a question, please come up. I'll start with a question to Munir. So I've heard it said from an individual who has been known as potentially bombastic that if you're doing a bicuspid aortic valve repair, that you should never need to further shorten your reference cusp. If you do, then you've either sized the graft incorrectly or you've reimplanted incorrectly. So what say you to that?
I wonder who that bombastic person could be, Joe. I agree that the key principle here is preserving the mobility of the non-fused cusp. I do think the non-fused cusp is an important factor in the durability of this valve. So that's, I think we all agree on that. The question is, when you have a situation where you have to a trade-off between prolapse versus adequate effective height, especially in cases where you are starting off with large root aneurysms, where the free margin is quite elongated, you have to sometimes plicate the non-conjoint cusp a little bit to gain the effective height that you need for durability. So it's a trade-off between not causing any restriction and yet having sufficient effective height that gets you that durability.
So no way you sized it incorrectly. Okay, all right. So to Ismail, we could play the videotape, but when you were cutting out the sinus, I heard you say, if you're doing a reimplantation, you can be a little bit sloppy. So my question is actually about central plication versus anywhere else. So I always thought of central plication partly because it just lines up that way and it's sort of easiest to find it there, and that's the area that sort of dips down. It's also typically a little bit more fibrous in that area. You made a comment that you should never go up near the commissures because that's where the stresses are greater. But we don't actually have a way of physically measuring those, and most of the computational fluid dynamics modeling that I've seen shows that the calculated or implied stress areas vary quite a bit depending upon the actual cusp configuration and how you've theoretically repaired it. So how do we actually know that that is where there's the highest stress and that we cannot or should not place plication sutures up there? Because sometimes that is the best place to put them, at least visually.
So first of all, we should never say never or always. So I say it like this just to kind of get the message across. Sometimes you might have to, although I almost never put any sutures there. How do we know? I think the computational fluid dynamics studies really do point to the pericommissural area being the area of highest stress. And I think when you look at valves from patients who have root aneurysms, the fenestrations always occur in the pericommissural area. That's the area of highest stress, and that's why they kind of tear the seams over there. So I always think whereas the free edge of the leaflet, the distal third of the leaflet is a non-load bearing part of the leaflet. The first 2/3, there's a bit of diastolic pressure. The last third is supposed to be straight like this. There's really nothing pushing against it. And so if you put your plications in the middle there, they're not going to be affected by that diastolic pressure. That's the idea behind it.
Good explanation. Do you want to restate your comment about reimplantation?
Reimplantation is a beautiful operation.
Right place to say that. We should stop it. Okay.
Sure. We have one question.
Just one quick question. I'm Brian Barris from Mayo Clinic, Arizona. So Dr. Chung and Boodhwani, I believe, presented 2 cases where you excised some calcium. So what criteria do you use to decide whether calcium can be excised or it's too much and you need to change to a valve replacement?
Thank you for your question. For sure, that's a judgment call, That's why I played with that particular case a little bit longer. And it depends on the patient factor. So if it's a very young patient who is desperate not to take warfarin for a while, and say you bought them 10 years or 15 years without a mechanical valve, maybe it's worthwhile. So you'll push the envelope obviously a little bit more in younger patients who want it. And then if they're older, then you don't hesitate and just cut it out. That's it.
You learn as you go, and our database is grossly incomplete. And from time that we analyze the studies, question like this comes up. I can tell you that all the valve spares I have done, and the cusps are very elastic. They do not fail at 20, 30 years. If they are sclerotic, they begin to fail. In my hands, a bypass surgical valve, and Chris found that was very aggressive, much more than I am in repairing bicuspid. Ask him what's happening 10, 20 years later. We're already operating on them. The calcification progresses, end up in the aortic stenosis. Remember, the moment you put a cusp in a non-compliant, rigid chamber like a Dacron graft, the mechanical stress might be skyrocketed. An elastic fiber, an elastic cusp, may have adaptive mechanism to tolerate, become thicker, just like the pulmonary in aortic position. I think it's a mistake, to be quite honest, to repair these valves. Unfortunately, I didn't, Chris Findell did, so you look at our data, his cusp by echo did not look very good in those that fail. 10, 12 years later, they're coming back with stenosis, not insufficiency, indicating the calcification is continuing.
Okay, last question.
Yeah, I have a question from Dr. El-Hamamsy. You're emphasizing on the role of the sinus of Valsalva in the function of the aortic valve. We agree about the role of sinus of Valsalva in the function of the coronary, as was described by Da Vinci. But in the valve, I don't see it really in clinically. We see lots of patients that have very dilated sinus of Valsalva, and aortic annulus is normal, STJ is normal, no AI. How you explain that? Looks like if the sinus alone is dilated, STJ is normal, annulus is normal, valve is not leaking. So what's the role of sinus of Valsalva?
No, I agree with that. And that, Dr. David taught us this for many, many years. If both of these diameters are not dilated, the valve would not leak. That's the function of the valve. What I'm talking about is the stresses of the opening and closing dynamics of the leaflets, how stressful they are, how much stress you have, and the velocity of opening and closing, whether there's any flapping during the systolic phase. So it's more about the motion of the leaflets. That's the role of the sinuses of Valsalva, because it works as an absorption mechanism.
We know Dr. David has a 30 years follow-up, no sinus of
I know
Valsalva.
all of that. We hear it all the time. But again, we wouldn't be born with sinuses of Valsalva. It would be much simpler for evolution to have us have a straight tube from the get-go.
Unless it's like an appendix. Okay, well, let's thank our expert panel. And let's welcome our next panel.